Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam from Houston, Texas. This is Cardiology Seminars brought to you by Triple N Media. On our YouTube channel, we have more than 200 lectures on various cardiology topics that are of interest to medical students, residents, cardiology fellows and nurses. Please do watch them, and also please do subscribe to our YouTube channel. The feature presentation is on pericardial tamponade, which is a cardiac emergency. Anytime you are called in a night or anytime you are called to the emergency room with a patient who is hypotensive, who is short of breath, who is having rapid heartbeat, who has jugular venous distension and has muffled heart sounds, you should always think about the possibility of pericardial tamponade, especially if the patient has a pre-existing history of renal failure or history of pericarditis or history of chest trauma. Let me repeat it. This is called the Beck's triad: low blood pressure, jugular venous distension, muffled heart sounds. So low blood pressure, jugular venous distension, and muffled heart sounds. It's called the Beck's triad. And if you see a patient having this along with shortness of breath, anxiety, and hypoxia, then always think about pericardial tamponade. It needs to be addressed immediately. There is rapid compression of the cardiac chambers, which results in reduced cardiac output caused by a sudden accumulation of a large quantity of fluid within the pericardial sac, which sort of chokes the heart. The accumulation of fluid can be acute, like in case of a trauma, or it could be subacute in case of viral infections, or it could be chronic, like in patients with dialysis or with chronic renal failure. Depending upon the acute nature of the pericardial fluid accumulation, the symptoms can occur at any volume inside the pericardial space that is large enough to choke the cardiac chambers. It can be classified as the collection of fluid around the heart could be localized. It could be all across the heart. Usually the pericardial space acts like a shock absorber. There is about 50 ml of serous fluid within the pericardial space, which helps the heart to sort of glide during each contraction. So in a case of an acute trauma, like doing cardiac procedure, if somebody were to puncture the ventricle while putting a pacemaker, just 100 ml of blood can create cardiac tamponade, because there has been no time for adaptation of the pericardial layers to stretch, and as a result, the pressure is going to be transmitted to the cardiac chambers, resulting in reduced cardiac output, low blood pressure. And in case of chronic renal failure patients, they can accumulate as much as 1500 ml of fluid around the heart before they develop serious symptoms of cardiac tamponade. And here's a chart showing the increase in pressure with volume, which is dependent on the rapidity with which the fluid accumulates. So if you take an acute viral pericarditis that accumulates a large amount of fluid in a short period of time, I'm talking about days, pressure inside the pericardial space goes up dramatically, resulting in symptoms of cardiac tamponade. Whereas in patients with like chronic renal failure, where the accumulation of fluid is over a period of months and perhaps years, then it can have a large volume before we see the signs of cardiac tamponade. So the presentation is important, and as a student, resident, or a fellow, our job is to look through their electronic health records and get a complete summary of their cardiovascular problems and any other conditions like hypothyroidism or malignancy, any of these things that may be accounting for the pericardial fluid, and then determine how much fluid is there and what tests we need to order and try to address this with intervention. Electrocardiogram may show sinus tachycardia. Here's an electrocardiogram from a patient with an acute pericarditis where you see ST elevation in multiple leads, but this may not be the typical picture you're going to see in an electrocardiogram on a patient with pericardial tamponade. You may see sinus tachycardia. There may be some pulses alternance. The voltage may be low. Besides that, there may not be many significant changes to help us. Chest X-ray would be very useful, and if you see a huge, like a globular, like an inverted wine glass, if you see a picture like this, you should immediately think about a large pericardial effusion and perhaps cardiac tamponade accounting for the Beck's triad. And you also can see this lack of pulmonary congestion, which may suggest that you're not dealing with a severe cardiomyopathy with acute pulmonary edema. What you're dealing with may be a pericardial tamponade. An echocardiogram is very useful if you have access to an echocardiogram in the emergency room or on the floors and you are able to generate the images. A quick look into the cardiac structures with the echocardiogram will really help you to pinpoint the diagnosis of pericardial effusion. As far as tamponade is concerned, you're going to need a full echocardiography done by experts so that we can see what are the findings that we can use to pinpoint the diagnosis of pericardial tamponade. Pericardial tamponade, after all the tests are done, is still a clinical diagnosis. And most importantly, if it is causing compromised circulation, an intervention is the best option. Here we can see the longitudinal axis of the heart. Here's the aorta, and here we have the left atrium. Here is the left ventricular wall. Here's the septum, the right ventricle, and there is a echo-free space behind the left ventricle, and this is the aorta. Any echo-free space in front of the aorta is considered to be pericardial effusion. In addition to that, here in this patient, we see a large echo-free space, which is supposed to be pleural effusion. So it's not uncommon to see in patients with volume overload, in patients with renal failure who could have both pleural and pericardial effusions. The main question is this patient having a tamponade? Just having a fluid doesn't necessarily mean it is an emergency. They could have large amount of fluid while the patient is not having any tamponade at that given time. Okay, here as you can see, there's a large collection of fluid here, and of course this looks like something that must have developed over a long period of time, because there is a stretching of the pericardium, and there's a huge amount of huge collection of fluid both anteriorly and posteriorly. This is what we call a swinging heart. The heart sort of dances inside this large pericardial fluid during each heartbeat. If you do a CT, I don't know if you want to do a CT, but anyway, it will show, here's the myocardium, the left ventricular myocardium, and here is the fluid showing going all the way around the heart. Here's the right atrium, and here's the right ventricle, and this is the left atrium. One of the hallmarks of pericardial tamponade is pulsus paradoxus. That is, during inspiration, the pulse pressure usually goes down less than 10 millimeters of mercury. On the other hand, if the pulse pressure drops more than 10 millimeters of mercury during inspiration, then it is highly suggestive of pulsus paradoxus. It can also be seen in like severe COPD patients, but given the clinical presentation, you think about tamponade when you see a pulsus paradox. Again, anytime you see a drop of blood pressure more than 10 millimeters of mercury during deep inspiration, that is highly suggestive of pericardial tamponade in that particular situation. Let's find out as why we see a significant drop in the blood pressure during inspiration in patients with pericardial tamponade. In a normal heart, the pericardial sac is very small. The layers are very thin, And during deep inspiration, the right ventricle gets more venous return and it expands laterally along the walls. Whereas in patients with a tamponade, because of the large fluid compressing the right ventricle, does not allow for the ventricle to expand laterally. As a result, it pushes the interventricular septum, and by that, the left ventricular cavity size is reduced, the left ventricular output is reduced, which leads to reduced stroke volume, which leads to reduced pressure. That's the explanation, which may be asked as a question in your exams, so you may want to remember this image which might help you. And here's a different way of showing. During expiration with pericardial fluid, the right ventricle is okay, but during inspiration, when there is increased volume coming into the right side of the heart, the interventricular septum is pushed to the left side, creating a smaller left ventricular cavity, and the smaller left ventricular cavity will lead to pulsus paradoxus, reduced output, which leads to reduced blood pressure. Here we have a pulsus alternans, and when we say a pulsus paradoxus, we are talking about a drop in systolic blood pressure of greater than 10 millimeters of mercury during inspiration. How significant is the pulsus paradox? If it's greater than 12 millimeters of mercury drop, the sensitivity is 98% and the specificity is 83%, whereas if it's greater than 10 millimeters, it is 98 and 70%. When we are diagnosing pericardial tamponade, we just don't rely on one number. We rely on the entire clinical picture. We look at the various peripheral signs, the patient's symptoms, presentation, chest X-ray, echocardiography. Then we put all the evidence together. Then we come up with a clinical diagnosis of tamponade. Cardiac tamponade, after all the tests are done, is still a clinical diagnosis. Here we have the pericardial effusion here, mostly posterior, and here's the right interventricular septum, the left ventricular wall, and here's the right ventricular wall. And let's look at some of the echocardiographic signs of cardiac tamponade. Diastolic collapse of the right atrium, 50 to 100% sensitive. That's a pretty wide range, which means it may or may not help. Specificity, 33 to 100%. I don't know if that's going to help you. Whereas diastolic, the duration of diastolic collapse of the right atrium as a ratio of the cardiac cycle length, if it's greater than 34% of the cardiac cycle length, then I think it is quite significant in terms of sensitivity, which is greater than 90%, and specificity, which is greater than 100%. Diastolic collapse of the right ventricle is a little bit less, but nonetheless, I think the specificity is fairly good. If we see diastolic collapse of the right ventricle, and if it lasts for a longer duration during the entire cardiac cycle, that may signify a pericardial tamponade and its effect on the hemodynamics as such. Inferior vena cava is also sensitive, but it's not specific to inferior vena cava, which is more than 2 centimeters and collapses less than 50%. It is quite sensitive, but it can be seen in a number of other cardiac conditions, so it is not really specific. Here is an echocardiogram looking from the apex, 4-chamber view, large effusion inferiorly at the apex and anteriorly also, and we don't see a big collapse of the right ventricle. Of course, you cannot make much out of still images. That's why a skilled echocardiographer is important to get all the images in various sites to come up with a comprehensive diagnosis. And here we see electrical alternance on the electrocardiogram in a patient with a large heart and obvious pericardial effusion. This may be explained on the basis that one time the heart is in the front and the heart is kind of wobbling back and forth. So depending upon which side the heart is, you get this electrical alternance. What is the treatment? The definitive treatment for patients with pericardial tamponade is pericardiocentesis. It is done by giving some numbing medicine here just to the right of the maneuver to the xiphoid process, and the needle is directed towards the right ventricular inferior wall. And of course, you put some suction on the syringe so that as soon as you see the fluid, you stop the needle. Generally use 16 to 18 gauge needle, and this is usually done in an intensive care unit or preferably in the cardiac catheterization lab where you have access to the angiographic view of the heart, and it can also be done using an ultrasound guided aspiration. Once you know you are in the pericardial space, you put a wire through this needle, and through the wire we insert a small pigtail which can sit there and drain the fluid, and we can actually leave the pigtail for a few days if we want to, because if the patient has recurrent fluid accumulation, that helps to drain the fluid. I have seen this done many times post-cardiac surgery when patients develop hemopericardium and it compromises their cardiovascular function. So this is one way for them to leave the pigtail to drain the fluid until the situation improves. So ladies and gentlemen, this is a quick summary of pericardial tamponade. All the pertinent points you need to remember. Please do subscribe to our YouTube channel where we have more than 200 lectures on cardiology topics. This cardiology seminar is brought to you by Triple N Media. I am Dr. Nik Nikam, and we will see you next time.